So thank you so much for the opportunity to speak today. I'm going to talk a little bit about a project I did with my wonderful mentor for my fellowship, Dr. Olivia Lee. We went to Mongolia back in March, and we did a cornea teaching mission. And so we focused on doing penetrating keratoplasty and also medical cornea teaching. So I'm going to talk and relate this a little bit to why is international ophthalmology interesting for academic ophthalmologists. So this is something that's very near and dear to my heart because I actually got interested in medicine and then got into ophthalmology and then got into cornea and glaucoma, all from my interest in international work in the first place. But maybe for some of you who are not as focused on that, maybe I can convince you that it's still a very interesting thing to do. So I think we're all aware as physicians generally that there's a very unequal distribution of preventable and treatable blindness in the world, and that the burden is asymmetrically on less developed countries because of lack of access to care, and especially there's a real dearth of lack of access to subspecialty ophthalmology care, in particular cornea transplants around the world, but others as well. Oops. Sorry about that. So why Mongolia? So actually why we ended up going to Mongolia is that as a medical student, as I started to get interested in ophthalmology, I got the chance to develop a program with a general ophthalmologist to go, he said, anywhere in the world that you would like to go, and I'll fund it if it works. And so we chose to go to Mongolia, and it ended up working superbly well, and I'll tell you why I think it ended up working so well, and I think it's an interesting question. So Olivia and I decided to go back to Mongolia where I had been previously, and there were really no cornea surgeons in Mongolia at this time, and there is a significant burden of corneal blindness there. It's a very interesting country. It's a very large country for the population. There's about 3 million people. About half of them live in very rural environments, such as this top picture here. And you can only imagine being a blind person or low vision person trying to navigate this kind of rural environment where your life really depends on horseback riding and herding of agricultural animals. It's not a pretty thought. So it's actually a very interesting place in terms of gender as well. So the men tend to be pushed towards manual labor, and that leaves the women to actually get educated. So actually most of or almost all of the doctors in Mongolia are women, and it's actually very poorly paid, but it makes it a very interesting place because we went to the ophthalmology department. It's almost all women, and they're very dedicated. They're there only because they really want to help others. They don't get paid very well, so it actually makes a good environment for teaching. There is minimal to no ophthalmology subspecialty care in Mongolia, in the entire country. They do a little bit of glaucoma. They have very minimal knowledge of corneal diseases. There are 2 cornea-trained physicians who actually had the personal wealth, for whatever reason, to go outside of the country and train in cornea transplants, but there is no eye bank in Mongolia, and so there is no access to corneas, and so there are no cornea transplants being done there currently. And so I'll tell you what we're trying to work on to work on that. So essentially most Mongolians who need any kind of subspecialty eye care other than cataract surgery are essentially out of luck. So I just want to take one moment to discuss, why do we need to travel all the way to Mongolia and invest these resources when there are plenty of people in Los Angeles who need eye care who maybe don't have great access to it. And I think that it's important to spend time doing work in our community as well, and maybe that's the first thing we should do. But I think it's important to think about doing international work because there are some important factors at play. So first of all, as I alluded to, there's no subspecialty training programs now. So there's no pathway for things to get better. So maybe if we have someone in our neighborhood who is underinsured or uninsured, we may have some pathway to try to get them either to a county hospital or get them insurance. But there's no pathway for things to get better, and so we're trying to help break that cycle. Also, I'm learning more and more as I get to work in more international programs that with a modest investment of time and money done well, we can have a huge positive impact in the right place. So I think it's important to consider, especially as academic physicians as well, that we do so much research and so much technology development, but we have so much technology that could be implemented to treat people who are blind just for lack of access to resources as well. So I think as we work on research, we should also work on distributing current technologies to places that don't have access to them. So where and when is it interesting to do international eye work? Well, it's very important, of course, to have a safe environment, and there has to be an unmet need, and those were certainly both true in Mongolia. But you also need to have the infrastructure necessary to accomplish your goals. So I had been there before, so I knew that there was a surgery microscope that we could use and that we could sterilize instruments, for example. If I hadn't been there before, I think we would have had to go first and establish all of this information and then return later at a later date to do surgery. You need to have physicians who are ready and willing and able to communicate with you both before and after, because there's a lot of planning that needs to happen. You also need to have the resources available for follow-up care, and that there's going to be clinical resources to follow your patients, especially when you're doing cornea transplants. And I think the most important thing on this slide is the local support and flexibility. So it might be a little bit different from if you go to do a cataract mission, for example. There might be a cultural stigma against receiving a cornea transplant or donating a cornea, and so you need to address that. But it goes all the way up to customs and local governments. Everyone has to be flexible and interested in learning and changing the ways they do things, and that's not something you can take for granted. So all of that is actually the reason I think this requires so much planning. And so there are many different kinds of eye care missions, and what we were working on was really a cross between medical and surgical skills transfer, and I think that is a place where academic physicians have a special role to play. And so we took a multifaceted approach to teaching, and so our main goal was to teach, not as much to do a high volume of surgeries. But we had 6 corneas that were donated very generously by SightLife Eye Bank, and that was a good number, we thought, for 1 week. And so we decided to take one surgeon who was trained in cataract surgery and focus on teaching her to do cornea transplants. And then we will continue to teach her more over time, and eventually she'll be the one to start a fellowship program and hopefully make a difference in the ophthalmologic community there. So, but every day we were also teaching in the clinic. We noticed there was a special need for teaching on herpetic eye disease, which was leading to blindness despite the availability of acyclovir in this country. And so we realized we could have a big impact by teaching specifically about herpetic eye disease. And we were also teaching how to manage post-op patients. We did wet labs and we did lectures as well on a daily basis. And so we don't have enough time to talk about all the planning that's required to do something like this, but let's just say it took about 9 months. And one of the interesting parts of the planning was I realized that in order to amplify our impact there, we really needed to have a surgical microscope that had a camera on it. So we came to realize before we left that there were going to be about 20 ophthalmologists from Mongolia who were going to be traveling from all around the country to come see us. And what a shame it would be if we could only teach one person at the scope. And so we were able to get this instrument donated so that we could actually bring a screen and demonstrate what we were doing and also record the cases so they could observe them later. And so these are our corneas in our bags. And I'll get back to this point that you need to have buy-in from the local doctors as well as local nonprofits all the way up to customs and immigration. So we actually got stopped in customs, even though we had all of these letters from all of our local partners. We got stopped for a couple of hours, but you can imagine trying to bring tissue into a country and all of these surgical instruments that are pretty valuable. You could completely lose a lot of surgery time if you don't have buy-in and documentation from all these places. So anyway, all of this work culminated in a very pretty purple Mongolian medical license for Dr. Lee, which I thought was pretty cool. And here we go, so Mongolia in action. So here is me carrying a very big box of cornea transplants from SightLife, and here we are at LAX getting ready to go. So everything that we needed to do cornea transplants fit into 4 suitcases, which was quite a feat. So we worked on teaching everything from how to evaluate a donor cornea for appropriateness for a donation, as well as screening patients for surgery and making a surgery schedule. So here's one very special little patient. It was a baby with bilateral sclerocornea, and this baby really had very little reaction to light in either eye when we first saw him. And there was a very interesting family history of sclerocornea in the family, which touches on the implications for research in places like this, because we think it might have a new inheritance pattern that maybe hasn't been described before. But anyway, this poor little baby was very low vision in both eyes with dense sclerocornea, and so we knew that we had to try to do something. And so along with this patient, we prioritized patients who were bilaterally blind in order to choose our best candidates for cornea transplants. So here we are at work in the OR. This is our Mongolian surgeon that we were teaching, and she did a fantastic job and is now competent in doing straightforward cornea transplants. We were teaching her everything from how to accept the tissue to how to suture and trephinate. So here are our patients after surgery, including our little baby. And here is just a small part of the Mongolian ophthalmology team, and you can see the predominance of women. Here we're screening, and I think that this picture is really nice because it really demonstrates our experience there. We found a place where every step along the way, the ophthalmologists were looking over our shoulder, wanting to know exactly what we were seeing and could they see it and could they identify it. So it was really a good buy-in from the physicians that we were working with. And here we are with our baby post-operatively. So this is an important part of what we did as well. This is the wet lab, and we also got 10 research-grade corneas donated from SciLife, which was very generous of them. And so we were able to bring enough equipment to do 4 mock surgery stations so that we were able to amplify the amount of surgery we could do, and so we taught them with pig eyes as well. And they really, really liked that. And so here is the whole mock surgery crew here. They really had a great time. I think they felt very empowered by it as well. So in summary, why do international eye work? So I think particularly in academics, there's an interest for the part of our international partners because there's an extreme lack of access to care and there's a lack of a pathway for things to get better. So I think that there is some obligation for us to at least consider getting involved. So along with research, I think we should work on distributing existing technologies into areas of need. For ourselves, I really think it's worthwhile. It gives a deep sense of satisfaction and remembering of why we're in medicine in the first place. But for eye centers, academic eye centers, it really builds teams and connections among people traveling. It's an incredible research and innovation opportunity as well. And it's also great for fundraising, and we got a huge amount of interest from our patients as well. And so I think it's just a chance to demonstrate the heart of an organization. And then it's amazing for trainees to build teams and build surgical kind of and medical knowledge and empathy. So future work on the Mongolia project. We're going to be returning in 2017, and we're working on expanding the cornea program. I didn't have time to even get into the fact that largely due to Dr. Lee, we're actually going to be partnering with SciLife to establish the first eye bank in Mongolia, and that is going to be happening this year. And we're also going to be working on a glaucoma program as I'm finishing my glaucoma fellowship as well. And so I think wonderful things that could be a great thing for UCLA and Doheny is already happening to a certain extent at UCLA, but to have a center for global ophthalmology to focus on quantification of outcomes and impact. And there's already a lot of international fellows here. And I think international fellowships are actually something that is getting expanded and getting more trendy in academic centers as well. So US-based fellows who want to learn how to implement projects abroad. And I think that's going to be something that becomes more and more common and interesting. And then for residency programs, aptly with the development of the Doheny residency program, which I'm sure is going to be an absolutely top quality program. It's great for recruiting residents who more and more are very interested in international work, and it's great for team building and medical experience as well. So thank you much to everyone who supported the program. We had a lot of donors, and thank you so much for a wonderful year of fellowship to all of my mentors and colleagues at Doheny.